Hello?
I'm here. I can hear you.
Hola. Was that like the 10th time?
Well, I understand. I have mine on mute too. I'm like, well, I don't hear anything, but that's fine. So which case studies, what questions, or well, let's see, what case studies do you want to start with first, and then what questions you have about the case study? So I'll know where to begin.
I guess we can start with... We can start with 51.
Okay. Everyone have 51?
No.
Okay. So is that the one for the renal calculi?
Yes, gallstone.
Ahí, I'm a calculus.
Si no te callas, te voy a mandar a tu cuarto, te aseguro. No, this is gallstones.
Okay.
And pancreatitis, I think. I'm reading over it again.
Got it. So this is, didn't we do this one already? We did a different one. We didn't do this particular one. All right. Not a problem. So what questions would you start on that case study?
What questions do we have, like in general, or like going from the whole case study, or what?
Right. What questions do you have about the case study?
Right now. On the labs, I wasn't sure whether my answer was correct. It says, which specific laboratory result points to a diagnostic of pancreatitis? So I know it's going to be both lipase, amylase. Which?
So would they be high or low? Because they gave you a set of lab results, right?
Right.
Okay. So would they be high or low?
Hers are high, super high.
Anybody that has pancreatitis, they're going to have an increased lipase and an increased amylase.
Wouldn't it be the opposite though? Because if it's not working properly, then why is it high?
It's inflamed, but remember those enzymes start to release. So that was what we talked about in class when we covered the case study for the smaller case study.
They're going to be released, you said?
When the pancreas is inflamed, what happens to the enzymes inside the pancreas? What do? They
get swollen too, they get bigger. Well, no, the enzymes, I'm sorry. The enzymes, they get trapped.
Do the enzymes get trapped?
I believe so, yes.
You all agree? That'll be the rest of the folks.
No, the enzymes get released into the bloodstream.
Okay. So when it's inflamed, it leads to the digestion of the pancreas by its own enzymes, right?
Mm-hmm. Yes.
Okay. So that would mean they can't deliver it to the duodenum appropriately, the pancreas swells, the enzymes continue to self-digest the pancreas and the surrounding tissues. We end up with malabsorption, but there's an increase in it. It's not working properly, but it's releasing a bunch of enzymes.
So it's still making it all the way swollen.
Right. So it'll activate inside the pancreas, self-digest the epithelial cells, and it'll self-digest itself in the cells around the pancreas. But you have an increase in the number value, because is that normal? Normally, would you have a high number of lipase and amylase or other enzymes?
No, there will be use when digestion is taking place.
So, but will it be 3,000, 2,000?
Oh no, that's a huge number.
Okay, so that is your key that this is producing a bunch of enzymes when it really shouldn't be.
Okay.
So that's kind of your hallmark or your indicator that your pancreas isn't working correctly. So
these two enzymes, they're going to be
elevated, which is kind of letting you know that the pancreas is having a problem, because those enzymes are only found where?
Then in the pancreas.
In the pancreas.
Right. Okay. Got it.
So in addition to that, then, because of proximity with the pancreas, this next set, which would be the liver functions, so your alkaline phos, which is the ALP, your ALAT and your ASAT, or the ALT and the AST, they're going to be elevated, which is letting you know that the pancreas may also be inflamed because of liver disease. So in order to understand this piece, let's kind of go back to the beginning of the case study. So in this particular case study, BK goes to, she's admitted to the step down, nausea, vomiting, left upper quadrant pain, and epigastric pain, which is basically right below the sternum. She wakes up with severe, sharp pain that's boring, radiating to her mid-back, right? So they give you a history that she smokes a half a pack of cigarettes. She denies alcohol. They give you her vitals. Do her vitals look normal?
Her temperature's a little high. Her O2, it's way low. It's 88. That's not normal.
Okay, that isn't normal. Her vitals look a little, her blood pressure is a little bit lower, but I'm not sure if it's because she's bleeding, but we got to find the rest of it out. She's dehydrated. We don't know yet. She's breathing at 30. That's not normal. If she was, 6, that'd be different, because kiddos breathe at about 30 breaths per minute. That wouldn't be abnormal or abnormal for them. Okay. So she's admitted to the hospitalist service, and she hasn't been seen by a doctor in years. So she has acute pancreatitis, not sure why. She gets a CT, but it's down, have to wait. But they do an ultrasound. Okay, there's no cholelithiasis. What is that? What is cholelithiasis?
Something in regards to the gallbladder and...
So it's conditions of stones in the gallbladder.
Okay.
So, but the gallbladder wall is thickened. There isn't any gallbladder wall thickening, I'm sorry. And she doesn't have any stones in the duct, in the bile duct. Mm-hmm. So they couldn't see the pancreas because there's a lot of gas. Okay, so they do a urine on her. The urine's dark. So what does the dark urine tell you based off of lecture? Why is the urine dark?
She's dehydrated.
Maybe.
An infection?
Don't wag it. Go back to your lecture notes, because there was a comparison and a contrast done between acute and chronic pancreatitis. So if you document it in your notes, I said that chronic pancreatitis has dark urine, and that's because of the excessive bile that goes to the kidneys or leaks to the kidneys. So this may be a chronic case of acute pancreatitis, which may be the reason why her urine is dark. So when you see dark urine, besides saying it's an infection, okay, well, we know she has an infection. She has an inflammation of the pancreas. But now we need to figure out the root cause of the respective dark urine and what it all means.
Okay.
So, okay, possible causes for pancreatitis would be biliary tract disease. So that's an obstructive process where the common bile duct may have a stone in it. Excessive alcohol use.
Mm-hmm.
She could have blunt trauma. She could have pancreatic obstruction. She could have high cholesterol, hypercalcemia, ulcers. So these are all potential ones. Okay. There are some medications like your opioids, your thiazides, your steroids. Those can cause the pancreas or might cause the pancreas to be toxic. So the other information you need from the ED nurse before you take responsibility of this patient or client is what type of pain medication was given and at what time.
Mm-hmm.
How did the patient respond to the pain level or to the pain medicine received? What else happens what else is in close proximity to the pancreas that may cause, that may be elevated? Let me just ask about that.
Well, we already talked about the gallbladder.
I'm sorry, not close proximity. What other enzymes or hormones does the pancreas produce that may be a problem?
The insulin, glucagon.
Okay, so we talked about the patient's glucose levels may be elevated.
Right, so she's not, her pancreas is not making enough insulin.
Right, okay, so what did the patients rate their pain before and after the meds, IV fluids, allergies, code status? These are all the things you should basically get in a routine report of a patient.
Mm-hmm.
Any antibiotics or other medications that may have been given? What's their INOs? What kind of lab values or labs you'll need to draw on the person or procedures? Anything that's pending, like consultations. So this is just additional information that you want to know.
Mm-hmm.
Any family members, do they know? And then receive a complete SBAR. All right, so preparation. What kind of preparation is needed before you go to CT scan?
We're gonna have her NPO.
Okay. How long does she need to be NPO for before she can, that they're, in case she receives oral contrast?
24 hours.
Not that long.
12.
4. So she has to
But doesn't her stomach have to be like completely empty?
We're not looking at the stomach. We're looking at organs.
Well, if she has anything in her stomach, then her pancreas is gonna still try to work and get rid of it, get whatever she has in her stomach. No.
We're not worried about that right now.
Okay.
So nothing by mouth, at least for 4 hours before the test.
Mm-hmm.
But if she received, besides oral contrast dye, and this is why I said it doesn't matter, because if you were worried about her eating food, etc., what other way can we deliver contrast dye?
IV.
We can give it IV. So then that will take the stomach completely out of it. That's why I said it doesn't matter.
Okay.
So the other thing you would make sure she would have is a patent IV so that they can deliver IV contrast dye.
Okay.
Then because she's receiving contrast dye, what other questions or preparational questions should you investigate?
Has she had any contrast before? Did she develop any allergies?
Like what? Allergies to what?
To contrast. To iodine.
To iodine or shellfish or iodinated dye, because it's kind of some type of iodine-ish dye. So we want to know about allergies to shellfish, allergies to iodine, or the dye itself. Okay, so we know that this dye has to eliminate through the body system. So what other piece of data do we need to look at?
We need to look at her kidney function.
We need to look at her kidney function. So we're going to check BUN and.
I'm sorry?
What are the 2 labs we're going to look at? So, I mean, you're right on the kidney function, but what are the two labs?
We're gonna look at creatinine and we're gonna look at BUN.
Okay, so the BUN and creatinine. Those will be the two things we're going to look at. All right. Now we can progress on to the case study. So she's restless. She's lying on her right side in a semi-fetal position. She's cool, diaphoretic, pale, poor skin turgor. What is she in now? Pale, cool, clammy skin. What does that equate to? Anybody?
You know what? It sounds like, what's that concept we're talking about? It sounds irrelevant, but it sounds like the symptoms for hypothyroidism.
Okay. But we're not worried about the reason. I can go with that. But pale, cool, clammy skin is a sign of shock, whether it's the hypothyroidism, whether it's trauma, whether it's dehydration, whether it's, heart failure and they're going into cardiogenic shock. It's basically the telltale sign of a person going into shock or having hypoperfusion. As I said, I can go with that, but this case study is all about the pancreatitis. Okay, so we're not going to cross over. But I mean, I like the correlation, don't get me wrong, but this is all about just strictly pancreatitis. But the cool, diaphoretic, pale skin, poor skin turgor, we're now talking about her moving into a compensated, meaning the body's now trying to correct the problem, okay? So her heart rate is 96, it was 97, there's no murmurs. Her pulses are faintly palpable in all four extremities. Is that good or bad?
That's bad.
Okay, so instead of breathing at 30, she's now at 24, but labored, and now she has 2 liters of oxygen, but she can only keep the sat at 90%. So we want oxygen sats to be at least 92 and above, okay? So we're in trouble. Her left lower lobe on posteriorly is absent. Is that good or bad?
That's bad.
So you want to hear breath sounds even if they're abnormal. So when you hear no breath sounds, that is never good. That basically means the person is close to going into a respiratory arrest. So all the other lung fields are clear. She's complains of nausea. She's dry heaving, hypoactive bowel sounds. Her belly's distended, firm, tender in a diffuse fashion, which means it's tender everywhere when you barely touch it. And she has guarding. So they're using electronic charting. Which of the following systems would you mark as abnormal?
Respiratory.
Yep.
Skin.
Cardiovascular because of her pulses.
So respiratory because of the rapid respirations, absent breath sounds, low sats. Someone said cardiovascular and because we're missing pulses, or we're not missing, they're diminished in all four extremities. Did somebody say skin?
Yes, I said skin.
Okay, so skin is correct. That's because of the pale, cool, clammy, poor skin turgor, dry mucous membranes. All right.
GI because of the tenderness.
GI because of the nausea, the hypoactive bowel sounds, the distended and hard abdomen. That's what that firm means. And that it is tender. And when it means to light palpation, it doesn't mean, it's basically you barely put your hand down on it and there's pain. We're missing one more.
Pain?
Not pain.
Neurologic?
Neurologic because she's restless but alert. She's lying on her side in the fetal, semi-fetal position. So those will be the 5 that you would document the most. So those would be your priorities. Okay, so now we have these lab values. We've already talked about the amylase and lipase, liver function, total bilirubin is elevated, which basically points to pancreatitis along with liver disease. The low albumin might be decreased with the inflammation or stress or the liver disease, we're not sure. But we definitely know she has an infectious process because the white cell count is 500, right? I mean, 17,500.
Mm-hmm.
Sorry about that. All right, so the labs that are most important in an acute pancreatitis situation, amylase and lipase, because remember the pancreas is an exocrine and an endocrine, and the exocrine part consists of the secretion units or the secretory units called pancreatic acini. So we talked about the acinar cells that produce amylase and lipase through the pancreatic duct into the common bile duct. So they travel into the duodenum through the sphincter of Oddi or Oddi, however you want to call it. Usually takes about 12 hours for that time, from the total time to self-destruction of, you know, the time release of the amylase and lipase. So it is stimulated with oral intake, which we talked about earlier, especially if the diet is high in proteins. If amylase and lipase can't get to where it needs to be, then the protein digestive enzymes are activated and they begin to digest the proteins in their environment. That's why the self-digestion of your pancreas happens. So now the pancreas is inflamed, the person has a lot of pain. So that's the whole process of why these labs are important, and then how the self-digestion comes into place in the first place. So we do the BUN and creatinine. So what do the BUN and creatinine tell you about our renal function? Whether it's dehydration or there's decrease in fluid overload. The creatinine reflects the filtration portion of the kidneys and their ability to handle fluid challenges. So the BUN rises when we have dehydration and decreases when we have fluid overload. So if you're looking at the BUN, and if it's increased, that lets us know about dehydration. If it's decreased, then we have fluid overload. Does that make sense?
Yes, ma'am.
All right, when we look at the creatinine part, this lets us know how the kidneys are filtering and how that filtering process is actually working. If it's not working really well, or if it's working, you know, excellent, it kind of gives us an idea of what it's doing. But it also lets us know if the kidneys can handle what they call a fluid challenge. What is a fluid challenge?
It sounds like anything maybe that's going to be challenging for the kidney, anything that might be different, that's not like a homeostatic state.
Okay, so in your nursing career, you'll be asked to give a patient a fluid challenge. So basically what that fluid challenge is, it could be 250 milliliters if it's an elderly person. For a person that doesn't have any fluid restrictions, it's usually about 500 is where they'll start. And basically when someone's dehydrated, then they will give them a fluid challenge to try to hydrate their body. And the creatinine basically tells you how well the kidneys can filter or function with that extra volume. Does that make sense?
Yes.
So her BUN and creatinine are both elevated, which basically means it's a reflection, or it might reflect that she's not hydrated but dehydrated. So what do the WBCs tell you?
Infection.
Okay, it could also represent necrosis of the pancreas. It could also represent an abscess outside of an infectious process. So we won't know if it's necrotic unless they do surgery. So now we have rapid respirations at 24. They're unlabored, and we still at 90%. We have the absent breath sounds, left lower lobe. Otherwise, clear throughout. The admission chest x-ray leaves a small pleural effusion. So give me 3 actions you could initiate to correct this problem.
To correct the pleural effusion?
To help correct it. So it doesn't mean that the one thing's going to fix it. It's going to be a combination of things. So what can you do to help facilitate minimizing the effects of this pleural effusion to the left lower lobe?
And with this, you're not talking about doctor's orders, right? We're
I'm
talking
not.
about nursing interventions.
We're talking about nursing actions.
Respiration therapy.
What's respiration therapy?
We're gonna tell her how, to show her how to take deep breaths.
Are you talking about like pulmonary toilet, where you have a person cough and deep breathe 10 times every 1 to 2 hours?
Yeah, something like that. And along with the incentive spirometer.
Okay. How often should she use the incentive spirometry?
Every 1 to 2 hours.
Okay, at least every 1 to 2 hours while she's awake. And what do you want to emphasize? With the incentive spirometry?
Want to emphasize her expiration.
All right. So you want to have slow, deep inhalations through the mouthpiece?
No, slow, deep whenever she's breathing out. Because that's what we're measuring with the incentive spirometer, right?
Do you guys agree?
No, you know what? You're right. No, inhale. We're sucking in the air through that little mouthpiece.
Okay, so slow inhalations through the mouthpiece.
Yes.
And then keeping the guide within the therapeutic range.
Yes.
What about the head of the bed, up or down?
Up.
So we want the head of the bed up. So these are all things that don't require doctor's orders. And then evaluate medication effectiveness, any supplements, antibiotics as needed. All right, so she rings her call light. She complains she wants something to drink, but she's NPO except for sips and chips. What is your response to her request? And what nursing action would help her complaints?
We're gonna offer her ice chips, and we're gonna tell her why. We're gonna educate her on what would happen if we give her anything to drink, like a big volume of something to drink. We're gonna let her know that it's gonna make her pain worse.
Okay. And so is it the pain or also the pancreatic function?
Both.
Okay. So it can stimulate pancreatic function if we actually do give her water or oral intake, and it will increase her pain and her nausea and vomiting, which will further elevate her pancreatic enzymes. So is that what we want?
No.
Nope. And it's going to extend the inflammatory process. So that's the biggest reason why we don't want to give them anything. We can also do like oral swabs in her mouth. That's only small amounts of ice water. So it's not a whole lot. All right, so she falls asleep. She seems to be peaceful. 7 hours later, you hear the alarm of her pulse ox. So now you go in to investigate, and it says it's 87%. What do you do?
Administer oxygen.
She has the oxygen already. So instead of administering it, how about making sure that everything's connected properly and that it's actually in her nares appropriately? So you know how when people are sleeping and sometimes they itch their nose and then the oxygen's, somewhere near the nares but not necessarily in it? Okay.
Mhm.
So make sure she's sitting upright, keeping her head elevated. What else can we do?
Make sure the tubing is intact. Make sure it's open. It has a good flow of oxygen.
Okay, we got that.
Make sure the O2 is actually turned on to 2 liters.
Okay, got that. So what else can we do? We got all the oxygen covering the basis on the equipment. So what else can we do?
Tell her to.
What was that?
Assess the skin again.
Okay, we can assess the skin, but more importantly, since we're having oxygenation issues, let's look at assessing her lungs. Okay. Let's see if there's been any changes in her lung sounds. And then, make sure she's awake, alert, and oriented because our breathing center is in the brain. So we don't want to make sure we don't have a change in her mentation. We can ask about her pain level. Other things we can do is the incentive spirometry, so the cough and deep breathing. We can do either one of those, so the cough, deep breathing, or the incentive spirometry. And why do we use those two things anyway? What is the purpose of those?
To see the capacity of your lungs expanding, or expanding.
Okay, and what are we trying to prevent when we're using incentive spirometry or having the person cough and deep breathe? What are we really preventing?
Hypoxemia.
How are we preventing the hypoxemia?
By allowing the oxygen to circulate.
Okay, so the reason probably why she has this pleural effusion is she had something called alveolar collapse. What is the word that means alveolar collapse?
Atelectasis?
It's called atelectasis.
Atelectasis.
So the reason why we're doing the incentive spirometry and the reason why we're doing having the patient cough and deep breathe is we're basically trying to keep the alveoli open. We're trying to prevent hypoxia by preventing the atelectasis, which is alveolar collapse. So this will now promote gas exchange or the diffusion of oxygen into the pulmonary capillary. So if these things do not raise her oxygen saturation level over 92%, then we can go to titrating the oxygen up. Does that make sense?
Yes.
So what happens if you, say for instance, I'm just throwing this out there, say for instance, you do all that, you increase the oxygen to 4 liters and your oxygen sat doesn't change. What should you do next?
We have to call RT and the doctor, but at the same time, are we raising up the oxygen to 4 liters without an order, or we're just gonna say this judgment?
You can actually increase oxygen. If your order is to keep her sats over 92%, and you're not getting that done with 1 to 2 liters, then what is your next step?
Bring it up, try to, bring it up to achieve a 92%.
So if you get to 4 liters and it's still not 92%.
We cannot do CPR until the doctor have another order for her.
So, okay. So we have a person who's, we're worried about their oxygen sats. We've increased it within our nursing room. We've gone up on our nasal cannula to 4% and to 4 liters. And honestly, 5 and 6 liters of air going through a person's nose really is just ridiculous. That makes no sense. If you can't get the oxygenation status up after 4 liters, 1 or 2 things. The first thing I would do, since we already know she has pulmonary effusion and her lungs have not had a lot of stressors, not that the lungs have had a lot of stressors, then I would call the rapid response team and her physician.
Call the what? I'm sorry.
The rapid response team.
Okay.
So if after the nursing actions that you can do, elevating the head, asking about pain, checking orientation, auscultating lungs, making sure the tubing and everything was good, increasing, the oxygen, doing the incentive spirometry, doing the cough and deep breathing, and we still don't have resolution, or we can't get our oxygen sats up to 92%, then we need what? We need some help. Do you see what I'm saying? You literally hit
Yes.
all of the basics that you can do within your scope to fix the problem. But if after that, all of the nursing actions with making sure tubing and everything's working, her bed is up, lungs are checked, pain levels checked, orientations checked, we've done the pulmonary toilet, the cough and deep breathe, the incentive spirometry, we've increased our oxygen up to 4 liters, and we still haven't had it. We're still at that 88, 87 percentile. Then we need to call the rapid response team, RRT.
Okay.
So then that will get the physician and all the respective parties there. So remember that her pulse ox read 87%, not 92. Or not 90, they were less than 90. All right, so now she's more labored. We call the rapid response team. While waiting for them to get there, you do a quick assessment. Lung sounds are absent in the left lower lobe and very diminished in the right lower lobe. Is that a new change?
Yes.
Yes.
Okay, so now we percuss. We hear a dull sound over the left middle lobe, the left lower lobe, up to the scapula tip. On the percussion, you hear resonance over the entire lung. On the right, in the left upper lobe, what is the significance of your findings?
Possible pneumonia.
Okay, so the absent breath sounds plus this dull thud type sound on percussions indicate there's an accumulation of either blood or serous fluid, which we already knew she had a pleural effusion, right?
Hmm?
Or it means that there's a consolidation, as you said, pneumonia, or she could have a lung abscess, or she could have pulmonary edema. So those are the 5 things, or 4 things that could be wrong with her. Pleural effusion, no, 5. She could have an accumulation of fluid or blood, so she could have a pleural effusion, or she could have consolidation, which could be pneumonia, pulmonary edema, or a lung abscess. So we get a stat chest x-ray. Now that small pleural effusion is significant in the left lower lobe, and it has now extended to the right lower lobe. So based on the evolving pleural effusion with evidence of decompensation, what treatment would the physician likely pursue? Can we leave all that fluid in there?
No.
So we're gonna have to stick a needle in it.
Yes, ma'am.
Okay. So basically, then all of your preparation would be around the thoracentesis. So I'm going to go on down, just basically understand we're going to now have to stick a needle in it to drain it out. All right, so we get some
Possibly water pills afterwards.
water pills.
Yes, afterwards. Whenever we remove the pocket for water. No?
Well, that's serous fluid collection. That's kind of different than, this is not a pulmonary edema. This is a little bit different.
So it's not going to work the same.
We're basically going to just pull that fluid out. It would be no different than if a person had ascites and we stuck a needle in their belly to pull out the fluid. Now, the one thing you would do is send it to the lab for it to be, if they determine if it's cancerous or anything like that. So they'll do a cytology study on that fluid.
Okay.
Okay. All right, so now we've removed 200 milliliters of the fluid. We give her antibiotics. We do a culture. She's on 3 liters nasal cannula. Her SATs are now 96%. It's been 72 hours since she's been admitted. She does show some improvement in her lab. The abdominal scan is completed. She has moderately severe pancreatitis, but no local fluid collection around the pancreas or no pseudocysts. There's no ileus. What's an ileus? What's an ileus? We talked about that, I think, lecture 1 or 2. I think lecture 2. No, lecture 1, when we talked about nasogastric tube. So that's paralysis of peristalsis. So it's the inability of the intestines to contract. Okay, so if we don't have peristalsis, then things get backed up, correct? And so you can end up with a bowel obstruction. All right, folks. I think this is the last 2, or got a couple more. All right. So what would you know, how would you know if BK was unable to tolerate the advanced diet? And that would be nausea, vomiting, right?
In pain?
And pain. She would have an increase in pain. What else would you expect? Because when you eat, then our enzymes get stimulated. So you would expect her amylase and lipase and white cell count to elevate, correct?
Right.
All right. If she doesn't tolerate it, what physiologic needs should be addressed at the 72-hour mark?
Nutrition.
What kind of nutrition?
She's gonna have to get either PPN or TPN.
She's gonna need TPN, or she's gonna need a feeding tube, so that way, so she can get nourishments.
A feeding tube.
A feeding tube.
Well, if we do a feeding tube, that's still putting food in her stomach. Isn't that still gonna?
Nope, the feeding tube would have to go beyond the ligament of trees to avoid stimulating the pancreas.
So is that one of those feeding tubes that go slightly into the small intestine?
Yes.
Okay.
So it'll have to go, it'll bypass the ability to stimulate the pancreas. Most will probably go with TPN versus even taking the risk that the tube ends up near the ligament of trees and stimulating the pancreas.
And you said a feeding tube. What's the difference between that one and the one that you put directly on your stomach?
Because if you put in a nasogastric tube, it's only going to the stomach.
Okay.
This would have to be strategically done if they're going to do a feeding tube. They would not just go and push it in. They would have to do that under some type of X-ray process. So they wouldn't it wouldn't be the one we would put in. Because we're only guessing that ours end up in the stomach based on the patient still being able to phonate, you know, the patient not coughing and gagging and this, that, and the fifth. And then we do an X-ray to make sure that it's where? In the stomach.
See.
Okay. All right, so now we're agitated, we're disoriented, we have tremors, we're hallucinating, blood pressure is elevated, her pain has not increased, and the pain medication schedule has not changed. No visitors since being admitted. So what's likely going on?
It's showing sounds like dementia, but what does that have to do with no visitors?
No, this isn't dementia. You have to think about what causes pancreatitis. What are some possible causes?
Infection.
Okay, but this is not infection. Go back to your causes. That was number 1.
Alcohol abuse.
Alcohol abuse. So although she denied drinking,
She's
but
having
now
withdrawals. Oh my God.
we're seeing, it's okay. It's okay. This is why we're doing these case studies. So she denied the alcohol, but it doesn't necessarily mean it was true. So usually 3 days, if you're an alcoholic and you haven't had alcohol in about 72 hours, you're going to start experiencing alcohol withdrawal syndrome or delirium tremens, which is usually common 72 hours after the last alcoholic intake. So now we need to call the physician and get orders and monitor her for seizures and things like that. I'm like, this dementia. I'm like,
Oh my God, no, she's a junkie. You know, and we can't help her if she doesn't tell us what she has or what she does.
okay, but we're just talking about, how do you keep the signs and symptoms with your respective, exemplar? And this is all we're talking about. We just talked about things that could be the cause of her having
The
pancreatitis. So she was diagnosed with acute pancreatitis. But remember, she had dark urine. Is dark urine seen in acute pancreatitis?
Chronic.
It's seen in chronic. Chronic pancreatitis is related to what?
The acute pancreatitis.
Alcohol abuse. That's usually one of the bigger things, and repeat bouts of pancreatitis. But she hasn't had pancreatitis or repeat bouts of pancreatitis. Remember, she didn't see a physician in years. So this is the first time. So that's the reason why in the beginning, even though it says acute pancreatitis, for her, this may be long-term use of alcohol that's led to this particular issue. Okay?
Yes. Yes, ma'am.
All right. So discharge teaching, we just, dietary measures. What kind of food should pancreatitis folks, once they can eat, what is our recommendation?
High protein, low carb.
Low fat, low cholesterol. Okay. Stop drinking. She needs to get a PCP so they can monitor, her further. Go to a GI referral. Alcoholic Anonymous, a support group to help her facilitate and kind of get to the root cause of why she's abusing alcohol. Make sure maybe she's drinking because she's not safe at home. I don't know. So that needs to kind of be discovered.
Meeting with the social worker to figure things out.
Yep. That would be social worker. What medications can she get? If she has pancreatitis, she's going to have the pancreatic enzymes, right?
Yes.
Okay.
Pain medication.
Okay. And then there's actually a medicine for that's used to treat alcohol withdrawals. It's in the benzodiazepine group. It's more of a sedative. but that's going to be, you know, that's going to be physician's choice. So chlordiazepoxide is one of the ones that they could use. I was trying to see if there was a Librium. That's the word I'm looking for. So they may put her on Librium. All right, let's talk a little bit about kidney stones. So since we didn't cover that, let me see where you are on the kidney stones. How do kidney stones develop?
With overproduction of calcium.
Okay, so I gave you the case study, the Word document case study with Alana as a 28-year-old nursing student. Let's do that one.
We don't have that one. We have 51, 59, and 6. Oh,
It wasn't a numbered one. It was one that just says case study renal calculi. It was actually a Word document, very similar to the pancreatitis one that we did in class.
Oh, I have it.
Okay.
You got it? All right. I know I did a lot of printing, so I know you guys have it.
I didn't get one. I was in the restroom.
Oh, Lordy B.
Okay.
No good deed goes unpunished. I'm so sorry. All right, so I'm actually going to, hold on, let me share screen real quick. If my computer shakes, I'm sorry. That's the puppy hitting the back of the computer. He's wanting somebody to play, but I can't play right now. All right, let's share screen, and then we'll do this case study. Share. And like, we don't have that. I'm like, yeah, you do. Okay, so can everybody see this?
Yes, I can.
All right. So we have Elena, 28-year-old nursing student who developed intense flank pain at the hospital site. She was pale, crying, and reporting excruciating back pain near the flank. She states that she's had kidney stones before, and this feels the same. So now she was diagnosed with a kidney stone. They gave her some morphine, ketorolac, which is Toradol, and she's on an IV drip, normal saline, 100 mils per hour, and they're going to strain all her urine. So what pain medication should the nurse administer and why?
The ketorolac.
Okay, so what kind of, can we give her the morphine for acute pain?
If I remember correctly, the morphine is secreted by the kidneys. So we can give it to her, but might get toxic.
Okay, or she may have problems with the urine, with excreting it out, is what you're saying?
Yes.
So we can give the Toradol. It's an NSAID for pain management. It's also an anti-inflammatory. So it will reduce swelling and ease the passage of the kidney stone.
Mama, can I find a table?
So I can meet with it.
All right. So why did they decide to give her 100 mils per hour? And should you question this particular order? So basically, is this the appropriate rate and solution for this problem? Yes or no?
No, the maximum is 40.
2 liters per day.
All right, so she is currently having a kidney stone problem, right?
Mhm.
And can we leave the kidney stone in the kidneys?
No.
No.
No. So this is an appropriate order. Fluids are encouraged, not restricted, around the clock. We need to help this stone come out. Now, the only time we would have an issue is if the stone was too big to pass. But the hydration also prevents further stones from forming. So the order doesn't need to be questioned.
Yes.
All right, so let's just, how do we get kidney stones? Are kidney stones soluble or insoluble?
Soluble.
They're actually insoluble crystallized minerals, and they're hard.
Okay.
So they're hard, insoluble, crystallized minerals and salts that have formed from your filtrate that's produced in the nephrons. So all the nephrons are in which we have millions of them, they exist in your kidneys. When people start to have kidney failure, they've lost about, or by the time it's recognized, they've lost about 60% of their functioning nephrons. It's those nephrons that causes you to produce the urine to pee. So they take the blood and filter it, remove out the minerals and salts from our blood. Then it takes from the tubule portion where parts of the filtrate will be reabsorbed, secreted, or excreted as urine. So the nephrons are pretty important for you making, filtering, and excreting urine. So when you have a kidney stone, those minerals or materials that are removed from the blood, there's a high concentration of those in the filtrate. And when that concentration of those minerals and materials are in the filtrate, they start to clump together and they form crystals. And those crystals then turn hard into stones. Are those a smooth crystallized stone, or is it a jagged crystallized stone?
Jagged.
It's gonna be jagged. And kidney stones are variant in size, meaning you can get a small kidney stone like a pea, or you can get a large kidney stone like a walnut. So it's different. There's different types of kidney stones, or different materials make up kidney stones. But the most common form is calcium oxalate. So that'd be OXALAT, oxalate. So when we end up with that high concentration of calcium oxalate, then they clump together and they crystallize and form a kidney stone or a renal stone. So the treatment's going to be based on the type of stones that are produced. So here with the nephrons, they've filtered the blood, they've removed a lot of the calcium or the oxalate. And where do we get oxalates?
From foods?
Okay, from foods or drinks, we do get them from that. Okay. So when we have that accumulation and we form the stones, then we end up, they grow, they get bigger, we get debris that sticks to them, they get hard, and then now they get stuck. So calcium oxalate forms in acidic urine because it has high amounts of calcium and high amounts of oxalate in the urine. So causes for someone having an increase in calcium would be from an excessive or taking a lot of calcium supplements with vitamin D. If they have hyperparathyroidism, increased salt intake, and usually from oxalates, if you have like a GI disorder, because normally they bind together calcium and the oxalates in the gut, and then it's excreted out through the stool. But if they have like ulcerative colitis or if they can't digest fats, then the calcium binds to the fat, leaving the oxalate in the urine. So this is how we end up with the high intake of oxalates.
Yes.
So if we have an increase in sodium, so like, that college food, the ramen noodles, the sodium, it is filtered into the urine, but if we have a high increase of sodium, it will now prevent the calcium from being reabsorbed back into the blood. And so now all the calcium is left in the kidneys, which is a good environment for crystallization to happen. So that's how sodium impacts, or high sodium causes kidney stones. One other, so that's kind of that piece there. So that's how stones are made. So are we kind of clear on how stones form? So, foods that have purines, salts, medication with calcium, those all form those calcium oxalate stones. Okay.
Also, the urinary tract infections, frequent urinary tract infections.
They can have a urinary tract infection. That is correct. But usually the most common one is because of the calcium oxalates. Okay. All right, so that's one type of kidney stone. Then we have the uric acid kidney stones, and that's because there's too much uric acid in the urine because of low pH or an acidic environment.
Yes, ma'am.
So this kind of goes back to the glomerulus. When the blood's coming through the glomerulus, which starts the whole filtering process, and uric acid is a waste product of what?
Digestion of meat.
Protein. So there's too much that end up in the body, so to collect in the capsule, that Bowman's capsule where the glomerulus and all that is, and it goes through the renal tubules and crystallize with each other. So usually if you have an increase in uric acid or an increase in, protein waste product, what condition do most folks end up with? When we're talking about uric acid only.
Gout?
It's gout.
Yeah.
So causes of uric acid buildup would be gout, dehydration, so the urine becomes more concentrated and acidic, therefore they form crystals in the filtrate. Diabetes type 2, or an increased intake of animal proteins and purines, that will also cause a uric acid stone. They have a couple that are rare. One's called cystine, Cystine. So cystine, Cystine. So this is from too much amino acid cystine in the urine. So this is a genetic issue, but that is also happening in the Bowman's capsule. The other one is struvite, Struvite. This is the rarest form, but it comes from chronic UTIs where the bacteria causes the urine to be too alkaline, pH is increased, and we have also magnesium, ammonia, and phosphate that's a part of that type of stone. Last stone, which would be the 5th type of kidney stone, is the one that forms in an alkaline environment of the urine, and that's known as calcium phosphate. This is a renal tubule issue. So if a person has an issue with their renal tubule, then they will develop a calcium phosphate stone. So stones can be anywhere within the kidney area. So you can have it inside the kidneys. So it could be either in the calyx or the pelvis of the kidney. You can have kidney stones in the ureters. So it could be anywhere in the ureter, whether it's the top, middle, or the bottom. Or you can actually end up with kidney stones in the bladder. So the neck of the bladder, though. So those are all areas where kidney stones can develop. So anywhere where the concentrations are high of the minerals and the materials, you can develop a kidney stone. So they're just not in one area. The majority of the time, people can pass kidney stones if they're less than 5 millimeters. But if they're greater than 5 millimeters, then they're going to have to be surgically removed. So this particular person, they were admitted, they're receiving IV fluids and pain meds. So that's usually what happens.
So we need each to know each stone where exactly is formed.
I can't hear you. I can't hear you. I'm so sorry.
It's okay. So we need to know the location of each stone, where it is formed in the kidney. Like we have to know where cystine is exists in the kidney, where it is formed in the kidney. We have to know it.
No, I'm just letting you guys know that the kidney stones do not always happen just in the kidneys. It can happen in the ureter. It can happen in the bladder neck. But kidney stones can happen anywhere in that kidney unit. Does that make sense?
Yes, ma'am. Yes,
from the kidneys to the bladder. Understanding what the most common types of kidney stones help you understand how to do patient education.
Okay.
So if the most common stones are calcium oxalate stones, then we talk about that. You know, some people their morning eye opener is a Dr. Pepper. So they never drink any water. Their source of liquid is something caffeinated.
Yeah.
And usually those people will end up with a kidney stone, a calcium stone.
Yes, ma'am.
Okay? So knowing the different types of stones and how they form also give you causes of kidney stones. So consuming foods high in oxalates and purines and salts, or taking excessive calcium supplements, those are going to form your calcium oxalate or your uric acid stones.
Okay.
Having recurrent UTIs is another reason why a person develops kidney stones.
Okay.
Having increased or having hypercalcemia, hyperparathyroidism, having anything that's going to those things, having that extra calcium, they're going to clump together. That's going to produce a kidney stone. Does that make sense? So they're
Yes,
going to
ma'am.
form salting and keep the urine alkaline. So anything that creates an alkaline environment, having a structural blockage, so the urine's just stagnant, where a patient may have like prostate problems, or where the prostate's enlarged and it kind of squeezes on the urethra, so the urine doesn't get out. So now we just have urine brewing in that area, keeping it in the bladder, just pooling the minerals. That will prevent an individual from, or that will cause an individual to have a kidney stone. If there's any type of strictures or deformities, then the urine can't get out. And so urine will now just collect. And now these stones will start to form. So too much uric acid, so gout, dehydration, increased animal proteins. That's the reason why a person will develop a kidney stone. Any type of absorption problems like ulcerative colitis, and we talked about that, and we're going to talk about it coming up, or Crohn's. We talked about that with malabsorption. But fats are binding, with the calcium in the gut, instead of the calcium binding to the oxalate to be pooped out. So now we can develop kidney stones from that. So all of these things, talking about the stones, just kind of help you figure out the causes as to why folks have kidney stones outside of family genetics, which is usually going to be a cystine stone for which, for that process. Folks that can't move around, so low activity, paralysis, they're going to have an increase in minerals. So the urine's going to be stagnant in the kidneys. Therefore, the more stagnant, we're going to increase the ability of stones forming. Does that make sense?
Yes, ma'am.
Okay. So just understand that as I go through these, it's just letting you know how these come into being.
Okay.
If you have if you have a renal stone that's in the kidneys, then it's usually in the pelvis. So that person will present with a dull, deep aching, like this young lady here, like Alana, in the flank, or at the costrovertebral angle. And that's where at the back, where the ribs and the kidneys are close together. Does that make sense?
Yes, ma'am.
Okay. If you have a stone in the ureter, so the stone moves, and then we have a lot of intense wave-like pain, because as the stone moves, then it's going to be more sharp. It's going to radiate. It can radiate to the scrotum for a guy and to the vagina for a woman. So that's going to be more of a ureteral stone because it's in the ureter.
Yes, ma'am.
Okay.
Is it possible for a stone to rupture the ureter?
It can. We're going to get to that, because remember, the stone isn't smooth. The stone is jagged. Therefore, as that stone is going down the ureter, it's scraping against the ureter wall, which is why we see hematuria. So we already know we're going to have pain. We know that we have two types of stones, one in the renal area, one in the ureter area, and they have two different presentations. But they, regardless of whether it's in the kidneys or the ureters, then we're still going to have hematuria. They're going to have nausea and vomiting because of the increased pain. They're going to have signs and symptoms of a UTI, so dysuria, cloudy urine, fever. They could have urinary retention. So especially if the stone is in the bladder neck. Or they could be asymptomatic. So until the stone starts to move to the ureter, that's when they'll start having signs and symptoms. So that's kind of the things we're looking for: pain, hematuria, nausea, vomiting, signs and symptoms of a UTI, retention, urinary retention, so they can't empty out the bladder completely. What type of pain do we have? Is it in a wave-like process? So as the stone moves, then we're getting, we're getting more intense pain with the movement, and we have pain radiating to us to the perineal area. So scrotum for guys, vagina for girls. What kind of pain? Is it deep, dull ache in the flank or at the costovertebral angle? Then we're looking at more of a renal stone. Does that make sense?
Yes, ma'am.
Okay. All right. What kind of complications can you have with kidney stones? And we'll start with infection, because we've kind of already talked about that. But what other complications can you have?
Obstructions.
Okay, so when the stone gets stuck in the ureter, then we're going to have a lot of backup or backflow of the urine. And so the pressure inside is going to increase within the kidneys. So there's a lot of strain on the nephrons. There's a lot of strain on the Bowman's capsule, therefore decreasing the kidney's ability to filter blood. So that's going to be a problem. What about hydronephrosis?
Yes, ma'am.
What's that?
That's where the kidney stone is stuck in the ureter, but the urine doesn't drain and it backs up into the kidney. So it's basically increased water in the kidneys or condition thereof. But now the kidney will dilate.
Yes.
So you'll have dilation or swelling of the kidney pelvis, the calyx, and then we'll have loss of function of the kidneys because of the dilation of the ureter. So we can end up with nephron damage.
Yes, ma'am.
What are some diagnostic tools? What can we do there? What kind of diagnostic studies would you?
X-ray for kidney, ureter, and the bladder.
Okay, I don't. There's like an echo or background noise, so I can hear partially of what you're saying, but I really can't tell what you're saying.
Yeah, it's X-ray of kidney, ureter, and bladder.
So KUB, okay.
Yeah. And intravenous diagram. This is IV dye. It's a iodide dye.
Okay, so what he
And then-
said was an IVP, so intravenous pyelogram with
Yes.
IV dye. So that's the iodine-based dye. So they'll give them the dye, do the X-rays of the urinary system. But we have to check for shellfish allergies. Make sure they're not. Check for pregnancy, if they're nursing, if they have impaired renal function, and we also have to ask them about metformin, right? Because those things will be an issue. Other diagnostic studies would be a urine test, so a UA, or do a 24-hour collection of the urine. So the 24-hour collection of the urine, that particular process is, you're looking at the concentration of ions, the calcium and the sodium. We're also looking at a concentration of waste products, so the uric acid, pH, we're looking at the kidney function. And so basically they're going to collect it in a bottle. And you got to keep it cold. It's usually like a brown jug. So you got to keep the whole specimen on ice. The first pee doesn't go into the jug. So say, for instance, you're going to, so, hey, sir, hey, Alana, we're going to do this 24-hour urine collection on you. Oh, you know what? I got to pee right now. Okay, go ahead and pee. That first pee doesn't go in the jug. It's when they pee subsequently after that. Those subsequent pees will be placed in the jug, has to be on ice, or it's going to alter the results. So that's a little bit more in depth.
I have a question, then, please.
Yeah.
Why we ask for metformin when we do the X-ray?
Because of the kidney function.
Because of kidney function?
Right. What did we talk about metformin? I think that was the last lecture. We want to hold metformin for when we're doing procedures for 2 days. Why?
Yes, ma'am. Yes, ma'am.
Okay.
Okay, yeah. Thank you.
You're welcome.
Can you fix your phone?
I don't know how to. Yeah, it's a terrible echo. It almost sounds like you have a microphone to your voice box, so to speak.
It's really distracting.
Okay, I will try to do that.
Okay, I'm so sorry. So we know that most people pass stones. We're going to give them pain medication, right? So, because the pain is going to continue until the stone is either passed or surgically removed. NSAIDs are usually ordered to decrease inflammation and help the stone pass because of the scratching that the scratched ureter. So as it's going through the ureter, it's going to scratch the lining. How much fluids we want them to drink? How many liters per day? This is going to be for our non-admitted person, because our admitted person, we're going to give them fluids like we're giving Alana, right? So,
At least 2,000 milliliters.
So
a day.
at least 2, but 3 to 4 liters per day if they don't have any fluid restriction. We're trying to dilute the urine concentration as much as possible. So we don't want to have that concentrated material remaining and forming new stones. And it also decreases the chance of a patient getting an infection. We're going to monitor INOs strictly, making sure, also check and make sure they don't have a UTI. More importantly, we're going to give them a strainer, correct? Why we're going to give them a little hat to strain the urine.
To check if the stone has passed whenever they urinate.
Yeah, 2 things. We're going to make to see if the stone does pass. That's 1. 2, the physician may order the person to collect the stone and then send it to cytology so they can determine what kind of stone it is. Okay, and facilitate treatment that way. Move around as much as possible. If the person is immobile, then turn them frequently to keep the stone, to help the stone move and not have urine that's stagnant. So, the person can always have a recurrence of kidney stones. So yeah, at least 2 liters per day to increase the, make sure the patient's flushing the kidneys to decrease the concentration of the materials inside and decrease the ability of stones to form. What medications are given to prevent stones? What medications? So if a person has gout, or if we're trying to prevent gouty stones or decrease uric acid levels, we're going to give them allopurinol, ALLOPURINOL. So that's ALLOPURINOL. And the other one is hydrochlorothiazide, which is a diuretic. So that's going to decrease calcium in the urine. What about calcium supplements? Should we tell them to take a bunch of those?
Calcium diuretics, you said?
No, calcium supplements. Should we tell our patients to take a bunch of those?
No.
No.
Absolutely not, because remember, the most common stone is a calcium stone. So we're going to limit calcium supplements. We're going to limit calcium in the diet. Should we? Should we limit calcium in the diet?
Yes, to prevent further kidney stones.
Actually, no. Oh my goodness. The only time we're going to ask them to limit calcium in the diet is if the patient has a metabolic problem and secondary risk for osteoporosis. So that's the only time we would tell them to limit. But other than that, no, it's not recommended. The bigger thing is the supplements. What about protein? Should we limit protein?
No.
No.
Protein.
You sure?
Yeah, we can limit protein supplements, but not your daily protein.
You didn't say don't eat any protein. But we are going to minimize our protein because we want to make sure we don't increase our calcium and our uric acid stone. What about salt? Do we limit salt?
Yes.
Yes, we do. So we're going to limit our salt to 2 to 3 grams per day. We're going to decrease our purines, organ meats. We're going to decrease drinking beer. We're going to decrease red meats. We're going to decrease seafood like scallops and sardines because those form uric acid stones. Give me some foods that are high in oxalates.
Spinach.
Spinach is
Chocolate, strawberries.
okay, can we mute that? So sorry. Okay, so we're gonna limit spinach, chocolates, cabbage, nuts, strawberries. Those things are high in oxalates. Okay, so those are things we're gonna limit. So we have a couple of treatments we could do. We can actually, do a procedure that introduces like a shockwave therapy. It's kind of non-invasive and it'll break up the kidney stone into little fragments so they can pass better or easier. So that's the ESWL or extracorporeal shockwave lithotripsy. We could place a stent so that it can pass. We're still going to strain the urine. We're still going to make sure they're mobile. We're still going to make sure we are controlling pain. And then the most invasive procedure that can be done is where they go in and remove the stone by a urologist. So this is when the stone is greater than 5 millimeters, is a percutaneous nephrolithotomy. So percutaneous nephrolithotomy. So those should have all been discussed in your Lippincott book. They can also do a ureteroscopy. This is a scope that they put in through the urethra, take the stone out via laser, or they can do that lithotripsy procedure where they introduce the shock wave. They can also place a stent in there to allow it to be removed. So there's a couple of ways that that can be done. Is there a vitamin we can also have our patients take to help decrease bacteria and the accumulation of kidney stones? Yes or no?
I'm sorry, what was the question?
The question is there a vitamin that we can recommend to our patients that they could take to help minimize the bacteria in the bladder, so that way we don't have an accumulation of accumulation of materials forming stones?
Yes, would that be vitamin C?
That would be vitamin C. You are correct. All right, we're going to finish up with this case study. So we talked about already why the urine is strained, because we're going to collect it. and we can send it for analysis. Some types of stones may be dietary in nature or require dietary restrictions, and we talked about those. So like the spinach and rhubarb and strawberries and chocolates and teas. She asked about calcium consumption. She takes a calcium supplement and she eats dairy for strong bones. So what should we tell her? Evidence-based research no longer supports the restriction of dietary calcium, but we're going to encourage fluids in a well-balanced diet. So unless they have some type of hypercalciuria, so basically high calcium in the urine. I think that was it. The ESWL, so what is it? The extracorporeal shockwave lithotripsy. So this is a non-invasive procedure that produces shock waves to break up the kidney stone. It may be discomforting, but afterwards, smaller pieces of the stone will pass easier. We're still going to strain the urine and send it for analysis, and they may have to repeat it. And I think that's the end of that one. Oh, I'm so sorry. All right. So that kind of concludes all of, all of the things that we covered or needed to cover for the exam. So can we use an NG tube with an acute pancreatitis person? And should we?
Yes.
No,
Why? Okay, so for the person who said no, why?
because whenever we're putting it from the, whenever we do an NG tube, it's going to go to the stomach.
Okay.
It's going to worsen the condition.
How does it worsen the condition?
It might, I'm sorry, because it might, it's going to stimulate the pancreas to produce more enzymes, digestive enzymes.
How does the nasal gastric tube do that? If you're going to put it to suctioning, if the patient's not eating.
Oh, suction. No, yeah, that's good. Then yes, we should. Yes, because we're emptying the stomach.
Because the question was, should we use or can we use an NG tube in a patient that has pancreatitis? And I just wanted to understand why it was no. But yes, if we can actually empty the stomach to decrease
Stomach
pancreatic
contents.
enzymes or decrease the release of pancreatic enzymes.
Okay.
And it will also decrease the pain because now we don't have the pancreas being stimulated.
Yes.
So if we do put in an NG tube, then we should expect for the patient to have some minimalization of abdominal pain or belly pain, in someone that has pancreatitis, because now we're kind of decompressing the stomach.
Mm-hmm. See.
All right. So we talked about Creon, I think it was, for the pancreatic and for the enzyme. We could also use pancrelipase, which is another medication or pancreatic enzyme for your patients with pancreatitis. How often should they take that? If you have pancreatitis, how often should you take your pancreatic enzymes?
Before a meal?
Sometimes you only take it in the morning with your morning meal. Should you take it at night? When should you take it? So this is after you've had a resolution and your patient's been, discharged home. When should we tell them to take their pancreatic enzymes?
Before every meal
With every meal.
or with?
So, you know, we talked about that in lecture, that, you know, they need to take pancreatic enzymes with every meal, not just sometimes. Okay. Can you use TED hose or sequential compression devices on a person with an arterial clot?
No.
No. So we use those for which one of those peripheral vascular diseases?
DVT?
DVTs.
And why use it with DVT and not arterial again?
You tell me.
Well, the one is on the artery.
Okay.
If we put a stocking or a compression stocking.
But why would you do, so if it's on the artery, then why would you need a compression stocking?
We still want the, well, I don't know.
So remember, you know, even though it's a clot, we have a clot in two different systems. They present two different ways. We have
Right.
unilateral coldness and decreased or absent pulses in one. And then we have warmth of, or unilateral warmth and swelling. So if we put a TED hose or a sequential device on a clot that's in the arterial system, what can potentially happen to that clot?
It can stay stagnant right there and cause a blockage.
It's already causing a blockage.
Are we releasing it if we do that?
You could, yes.
Are we making it an embolism?
Yes, we're not
But
trying to
wouldn't
create that situation.
So wouldn't that happen the same with a vein?
Why do you have a clot stuck in the vein? It's a vein. And not that it's any less significant, but what is the purpose of that happening in the first place? Is because of lack of circulation, decreased circulation? We put them on to prevent clots in the first place. That's the reason why we use those SCDs. So if they have a history, you know, of deep vein thrombosis, or even if they don't have a history, if they're not going to be as mobile, then we're going to put on SCDs or TED hose to prevent clots. But we don't use those compression devices on arterial clots. That's a whole nother treatment modality.
Okay.
So just because you can use a device for one situation does not equate to using it in all situations. And we talk about how clotting happens and all of that.
Right, but I don't see the logic behind that, though. I can't understand it. Why is it that? Because we're still trying to help with circulation, which is the purpose of the compression stockings, is to help with circulations, right?
Okay.
But at the same time, you know, whether we have the blood clot or not, whether it's in the vein or the artery, we don't want it to turn into an embolism. So if it's going to form an embolism in the vein,
you're making the equation that this is going to create an embolism if it's in the venous system. That's two different pathways. So if you now take something and you have a You have a arterial clot. The person is not receiving blood flow distally, and you're now going to put another squeezing mechanism on it. How are you improving circulation? We already have a clot. We don't have circulation. So now we're going to squeeze it more. We're going to add another pressure to it.
It's going to worsen the circulation.
With a DVT, you have circulation, but you have swelling in one area.
Okay. So let me see if I'm right. So with one, you do have circulation, whereas the other one, you don't have as much circulation. Is that right?
One, you don't have circulation because once you have an arterial clot, there's nothing getting beyond that distally. So now we're going to take that and now add some force to that to do what? What is the purpose of that? The other one, you have poor circulation. However, we need to improve circulation. So we can now add something to it to improve circulation. The other one, we're not going to improve circulation.
Okay, got it. Understood. Complete block, not a complete block.
Right. Okay, and that's why the leg is warm and not cold.
See.
Okay. What is an HDL?
The bad cholesterol.
HDL.
Oh, HDL, that's the good cholesterol.
That's the good cholesterol. Okay. LDLs are the low density lipoproteins. So or you can say lousy or however, whichever helps you remember one better than the other. So if you're trying to, how can you assist a person who has high, low density lipoproteins if you're trying to improve their health status? What types of foods would be appropriate for them? What would you recommend?
What types of what? I'm sorry?
Foods.
Recommend healthy fats like avocados, olive oil, nuts.
Okay. So other foods. Because am I going to eat avocado and nuts on a regular basis?
Mm-mm.
Okay.
Like eggs and fish.
Okay.
You'd want to cut red meats, right?
For sure. So those simple carbs, like your candies and things like that, we want to cut. Whole milks, things like that. Red meats, we want to cut out. So, if you're trying to improve health or cardiovascular health, and you need things like green leafy vegetables and spinach and kale and your more complex carbs to help get your lifestyle better. So, I can go with your fishes and leaner meats, but red meats definitely would not be the way to go on that. Be more of your fish, your broccolis, all of your green leafy vegetables, your spinach, your collards, your kales. Those would be a lot healthier. Not your iceberg lettuce that has no nutritional value, but your greens. So, because usually that has like your baby spinach leaves in there. Romaine lettuce is a lot better than iceberg lettuce, but there's other lettuces that are better. So for pediatric patients, do they have a high or low metabolic demand?
A high
They
demand?
have a high.
They have a high metabolic demand. So will they have hyper or hypoglycemia?
Hypo.
They will have hypo. So under stress, pediatric patients will have low blood sugar. For adults under stress, we will have what?
Hi.
We'll have high blood sugar levels. So if you get stressed, and that stressor could be a hospitalization, it could be an illness. So those types of things will then increase the blood sugar level. So they will release, those illnesses will cause the release of hormones that actually keep your blood sugar level up. So what kinds of things will cause a person to have poor circulation? Whether they are modifiable or non-modifiable.
Genetics, age, smoking, diet, lack of exercise.
Okay, so if you have hyperlipidemia, that can affect where you have plaque or buildup along the arterial walls. Smoking, the nicotine in the smoking actually causes vasoconstriction. High blood pressure, that can also that causes vasoconstriction, so that can lead to, peripheral vascular disease or peripheral arterial disease. So there's a lot of different elements. Diabetes, we can add that in there as well. So if you have a person that's had belly surgery, and it doesn't even matter what kind of belly surgery, if your patient is complaining of, if your patient has gas or belly distension, what can you do?
Have them walk around.
They need to walk around. What happens when you get them up and they're walking?
Their stomach, their gut starts moving, which helps get rid of the gas.
Exactly. So, if they have laparoscopic surgery, basically they end up filling their entire belly up with air. So in order to decompress that, then what you do is get them walking around. The walking, they will now pass gas, and then, they can move on to the next step. So it actually helps with peristalsis and gas elimination, which would then decrease abdominal distension. So for your sickle cell folks, what if you have a person that refuses, pain medication because they don't want to become addicted? How do you address that?
That the incidence of addiction is low.
Okay.
Warm things.
I'm confused. Help me out.
I'm thinking about heat pads. There you go, heat pads. Heat pads?
We're talking about we're talking about people being concerned about becoming addicted to pain medication with sickle cell. So I'm asking you, how do you address that with your patient?
Oh, how do you address that? Okay, well.
Yeah, that's why I was like, what's the 111? I mean,
you know what? I thought you were asking, okay, what's an alternative for pain?
No. Okay, so we've already established in lecture that they need pain medication. That they do. So, and they will require a lot of it. But if your patient said they're refusing the pain meds, so my question to you is, how do you address that? And so someone already said that, the addiction process is low. And that's not just for sickle cell. You will have a lot of patients that are on PCA pumps post-surgery that will not push the button because they don't want to become addicted. And what you have to explain to them is that, we need to manage your pain so you can get better. and you have to explain to them the physiologic changes that happen from no or not having appropriate pain relief. You know, elevated blood pressure, heart rate, etc., more adrenaline being tanked into the system, which is what we don't want. So we want to make sure that they are aware that they need that pain medicine. You know, acknowledge their concern, but it's still, they need it. It's a medical, it's needed. They just can't say they don't want it. I mean, they can, but the pain isn't going anywhere. Ice and elevation and all of that, that's just not going to work. So, you know, we don't want them to end up with the physiologic issues and vasoconstriction and things like that to occur. So what are some assessment findings with Addison's disease? So what would be some signs and symptoms that you would say?
Bronze skin.
Okay. That's it?
Salt cravings.
I didn't hear that, babe.
Salt cravings.
Salt cravings, okay.
Low cortisol.
Okay, low cortisol.
High potassium.
Okay.
Low sodium.
Okay.
High potassium.
I think someone said that one already.
Okay.
Postural hypotension.
Okay. Anything else?
Depression and high pulse rate.
In Addison's disease, don't they have low cortisol levels? So in Addison's, they have low aldosterone and cortisol, right?
Yes.
Because remember, in Cushing's, we have just only low cortisol, so C and C. But in Addison's, we are now adding aldosterone to it, right? So go back and review those different changes. Because those I gave in class, and then I actually went back on that last week in the Zoom session. So that way there wouldn't be any issues. But, you know, we did talk about the hyponatremia because of the aldosterone. Remember, aldosterone has sodium and salt follows the water. That's because it's part of sodium and water retention. The aldosterone is. So if we don't have it, then that means we have hyponatremia. We're also going to have hypoglycemia because in Cushing's we have hyperglycemia. And we're going to have hyperkalemia, which is the increase in potassium. So, you know, they have the muscle weakness, the anorexia, fatigue, the orange peel, dark pigmented skin, you know, hypotension. So it's, you know, it's in your readings as well. All right. So You know, there's 50 questions, A, B, C, or D. Read your questions, you know, don't answer too quickly.
We have an hour and a half, right?
I think it's 75 minutes. That's an hour and 15 minutes. 50 questions. So how
The
many?
time decrease?
I'm sorry?
Did the time decrease? I thought it used to be 2 hours.
The 2 hours is you're going to do the cooperative review.
Oh, okay, okay.
Sure.
So you take your test, then you get broken up into groups, and then you'll have 30 minutes or so to do the cooperative review. But there is a decrease in time. If you go to, let me just double check so I'm not saying the wrong thing. You go to eCampus, and under the handbook, and it'll talk about testing times. And I'm pulling it up as I'm talking, but I have to get a code on my phone since I'm not at work, technically. All right, give me a second to wait on this stupid code. So while I'm waiting on this code to come through, how many of you have been doing the raising the bars?
I have.
Here.
If you didn't do the raising the bars for this exam, then
Do you want some?
you may get overwhelmed trying to start them now,
Stop.
but I will highly suggest from this point on to do those raising the bars. They're already in your course board, and they will help you prepare for the test. It will also help you in preparation for HESI at the end. So don't let those, don't let those go to waste. Those things are there to help you be successful. Okay, code just got in. Let me go back here. Here. All right, so I'm going to share my screen. Okay, so you go to community, nursing, and nursing student handbook. Policies for testing. So that's all the policies related to testing. Here are your unit exams. Oh, you get 80 minutes. My bad, I actually shaved you off 5 minutes. So 80 minutes and then 30 minutes for cooperative review. So that's 120 minutes, 110 minutes total. So you'll spend 80 minutes on the exam, and then you'll have 30 minutes to do the cooperative review, and then that'll be that. Make sense?
Yes, ma'am.
Okay. All right. Are there any other burning questions? And then also in your course, have you guys not seen your raising the bars?
On eCampus?
Yeah. It's in your, it's, okay. So again, I'm just going to share my screen just in case you haven't seen it. So here's your course board. They're right there on the left-hand side. And, you know, one's 2 points, but they're right here. So these would be the things that I would have been, you know, opening up earlier on. But that should be what you saw.
Okay, ma'am. What's the best resource that we can practice on, please?
Say that again.
If we need to practice, what is the best course resource to practice?
For breakfast?
Practice.
Practice, ma'am. Sorry.
I didn't understand what you're asking.
Practicing for practicing.
I think she's asking what's the best resource to practice questions.
To practice questions. You actually have that in your Lippincott.
Okay.
So are you not able to get good practice out of Lippincott?
No, I am able to practice on it. I just so this is the best resource to practice.
Okay, so this is what I would do. For the practice questions, I would use more of that for HESI.
Okay.
What you guys need to do for this is understand the concepts. You know, what's involved with malabsorption syndrome? Who's more prone to having a malabsorption syndrome issue? So all of these different things, peptic ulcer, these are all the things we talked about, Carafate, H2 blockers, proton pump inhibitors, the side effects related to those, complications related to those, your nursing interventions, all of these things are here. So, you know, to prevent gastric obstruction, okay, NG suctioning, reposition side to side for effective suctioning. These are all the things that you would actually incorporate as part of your nursing management to, you know, to help the individual. So if you haven't specifically gone through and looked at these raising the bars, then this is going to be kind of a quagmire. Okay. So my suggestion to you today, you know, I would use them as a guide, but as far as trying to answer all these questions and put it into your notes for studying purposes 2 days before the test will be counterintuitive.
Okay.
So this would be stuff that you should have done beforehand. So after Monday's test, I mean, trying to do all this now, you're going to be so overwhelmed, and this wouldn't be the thing to do now. If you've already been using these raising the bars, then, you know, what I'm saying to you would just be more, kind of like old news. But if you haven't delved into those, then I would start with gas exchange after the exam on Monday. And then I would be looking at, you know, those concepts related to gas exchange. Does that make sense?
Yes, ma'am.
So I would not spend time unless it was just kind of a check that you already have these things in your notes. But if you haven't even started it, then don't even start it, because you're going to end up stressing yourself completely out. But moving forward, this is what I would be going to, because these are all the things that we would be covering in class, or the things you would be responsible for knowing for the exam.
Okay.
So, I mean, did you all not, when I kept talking about the raising the bars, did you not understand what I was saying? What?
I understand.
Okay. So, you know, if at any time, if I'm, you know, saying something about find so-and-so and such here and there, then if you don't know what I mean, then say, can you tell me where that is? Or can you tell me what you mean? So that way you're not thinking I'm just making some stuff up. But those raising the bars are a great tool to utilize.
Okay.
And it will help you stay organized, because if you do those, then when you get down to your comprehensive exam, you'll have everything of what you need readily available of stuff that you should have learned over the course of the semester. Now, all you have to do is study it.
Okay.
Sí.
So you would have already put in the legwork. But if you wait until the end to try to do that, that's just going to be so stressful. And during that week that you don't, after you take exam 4, we don't have lecture that week. You still have clinical. And then you take that comprehensive exam 5 that following Monday. That's not the week to be laying down and Cadillacing and parlaying and, I get a break. No, that's the week you need to be studying every single day, starting from after, you take exam 4. Because now you have the comprehensive exam, and then you also have HESI. So that's going to be the time for you now to really start digging your kneecaps in. So that way you don't get to the end of it and not be successful. But you're laying the groundwork. If the raising the bars help you lay that groundwork all the way throughout the course, all the way to the end of the semester. So the practice questions, you've already been doing that through your pre-quizzes and post-quizzes, and then you can set them up within Lippincott to quiz yourselves on specific areas all on your own. So, for right now, from something that's happening 2 days from now, you can quiz yourself, but those are things you could have been doing already on your own.
Yes, ma'am.
Oh, if somebody else have motorcycles driving by, I have that happen in my area too.
Sorry about that.
Oh no, I'm just being funny. Don't mind me. Okay, so it's early enough in the day. Hopefully, you don't have a whole lot of things on your plate. You can get, start getting some of these things done and worked on. And, if you're retaking this course, readmit, whatever, don't call that out here. I'm just basically saying, look at your notes you had previously. Maybe you're taking notes differently. Maybe you're studying differently. But you guys have to be putting in minimum 18 hours a week studying for your coursework. So you're not going to be able to get through with a 1-2 skip a few. Books have changed. Material overall is pretty much relatively the same. Questions, tests have been updated. There's a lot of different changes that have been made to make sure we're ensuring that you guys, when you get to that point, you're successful on NCLEX. But the work starts with you all.
Yes, ma'am.
All right, guys. Unless there's any other questions, and I'm going to sign off.
No
Thank you,
questions
ma'am.
here.
All right. We'll have a good weekend. We'll see you on Monday.
Thank you, ma'am. See you Monday.
Thank you so much.
You're welcome.
Bye-bye.
Bye-bye.